Good evening, one and all. It's as has been mentioned, uh, we had missed this session, but it's not a session worth missing. So we are going to enlighten you all on enough information about this session. And for that, we have Dr. Sunil Kumar, who is who is known to all of you. He is the additional director for Palem India Trivandrum, and it's also a teaching center. He is lead for clinical services, academics, research of Palem India, and he has a very wide experience, 20 years of experience in palliative care, and he is a mentor, guide, and a clinical lead to people who need information on A to Z of palliative care. Without much ado, I hand it over to Dr. Sunil Kumar to take us through the session today.
Thank you, madam, and good evening, everybody. So we will go on to the session straight away. I hope the PowerPoint presentation is visible.
Yes, it is. It is seen.
Okay.
Clear.
So methadone. These are the objectives or the points which we are going to discuss. Methadone is different from other opioids. That's why we are going to take this session separately. Then some of you might have heard of the problems associated with methadone. So it is also important for us to understand are there any benefits, and when we look at the patient and start methadone, what are the benefits that we are going to get and what are the risks, and can we select methadone for at least a group of patients for pain management. Then we have to have some parameters to monitor the use of methadone so that we can use methadone safely. Then we will also discuss who are the appropriate patients, because we need not start each and every patient on methadone. So we should have ideal patients to start methadone, at least when you start methadone for the first time. And most of the patients would be on another opioids like morphine or fentanyl. So how can we convert these opioids into methadone? So these are the points which we are going to cover in this session. Okay. I would like to start with a patient story, and she's a 30-year-old woman with Ewing sarcoma, which started as a small swelling at the sacral area in 2016, and she received chemotherapy and radiotherapy. And for the next 2 years, she was okay. But in 2018, she started to have pain on back and legs. And the oncologist advised to take an MRI, and it came as disease progression with the extension from S1 S1 vertebral body, along with compression of L5 and S1 nerve root. A PET scan was also done, which showed pleural metastasis. So you can see this is the pain distribution. It starts at the low back, going on to the right leg. And we can see the patchy areas of pain. And these are the pain score at rest. And she described it as burning as well as shooting pain, which gives her some relief on lying down. But with any movements, it increases the pain, so that she literally lies down on the bed all the time. And she was staying in the upper story of a or first floor of a house, and actually she was restricted to four walls of that house, and she was unable to sleep because of this severe pain. So you can see in March 2018, she was on morphine, 10 milligram Q4H hydroxyase, amitriptyline 75 milligram HS. That's a good dose of amitriptyline. Pregabalin 150 milligram BD, and that's also a very good dose. And she also received dexamethasone 16 milligram from another palliative care physician, and there were no pain relief. So, can anybody tell me what would you do at this situation? Patient is on morphine, amitriptyline, pregabalin, dexamethasone, no pain relief. You can either unmute and speak, or you can give your answers in the chat box. Anybody? Anybody? Okay, Dr. Sushil want to straight away start on methadone. Anybody else? Methadone is not available freely, or it is not used by many palliative care physicians. So during that time, the treatment team, I can see Fandom impact. Yeah, yeah, that's an option. But the treatment team decided to start her own epidural analgesia with the ropiacaine and morphine. Initially, the patient had some relief for about 18 hours. That was not satisfactory relief, uh, has very little relief for 18 hours. But even that was precious for the patient because she was suffering from pain for many days. So the uh, treating doctor, he was an anesthesiologist, and he continued to put him on epidural analgesia by reinserting the epidural at different sites. And they went on for almost 2 months with epidural. And then, uh, anyway, we cannot keep a epidural for a long time. So even though they reinserted at different points, finally it has to come out. So they decided to take out epidural because of the reason. One is there was no proper pain relief, and the other one risk of infection. And they decided to start her oral morphine. So they started with the 20 milligram of morphine for hourly and the services. And after a day, they increased the dose to 40 milligram uh, to 40 milligram for hourly and the services. And then started on amitriptyline with the 25 milligram. Later, they titrated up to 75 milligram. Pregabalin also started with 75 milligram and later to 150 milligram. And there were no satisfactory relief, and the patient had delirium and myoclonus. So can anybody tell me um, why this patient has delirium and myoclonus? Anybody? Why the patient has myoclonus and delirium? What does it indicate? Brain metastasis? Madhu Chandran says morphine, brain metastasis, high blood levels of.
Sir, amitriptyline.
Okay, morphine. So delirium and myoclonus. So those are two symptoms when the patient has um, toxic symptoms of morphine. So toxic symptoms means either it can be due to when you administer more than the required dose of morphine, or when the patient's pain is poorly responsive to uh, when the patient's pain is poorly responsive to opioids. So those are the two reasons, or else there may be one more reason. If the patient has a renal failure, then also morphine can accumulate in the body, which can cause delirium myoclonus, which are known as more opioid toxicities. Okay, so this means we cannot increase the dose of morphine, or even we have to reduce the dose of morphine. Uh, So again, this is the pain pattern, and patient is on morphine 40 milligram Q4 SIS, amitriptyline 75 milligram, pregabalin 150 milligram BD. So what are you going to do for this patient?
Sir, Radha ma'am, were you able to hear anything?
So what can we do to manage her pain? So as I told you, this was one of our early patients for whom we started her on methadone. Okay. Um, so um, we plan to start our own methadone. And when we looked at the literature, you can see these are the methods by which you can convert a patient to methadone. 3 DS, that is 3 days each. Then rapid conversion stop and go method, ad libitum stop and go method, German model, outpatient titration. So we were not sure which method we need to start. Um, but many people have advised us to start on 3 days each. So um, as I told you, when you need to convert a patient from morphine to methadone, you need to understand what would be the equivalent dose of methadone you need to start. So during that time, and there was this equianalgesic ratio. If the patient is less than taking less than 30 milligram of morphine, the initial dose of methadone would be 2 is to 1. So less than 30 means it would be 15 milligram. 30 to 99 milligram of oral morphine per day, 4 is to 1. Uh, so our patient was taking 240 milligram because she was taking 40 milligram every 6 hours. So it would be 240 milligram. So you can see the conversion ratio here for patient who is taking oral morphine equivalent between 100 to 299. The initial dose is 8 is to 1. Okay. So 240 divided by 8, that is 30 milligram. And when we convert a patient from one opioid to another opioid, you need not start equianalgesic dose because each opioid acts on receptors in a different way. So we need to actually reduce 30 percentage from the calculated dose. So that is known as incomplete tolerance. Okay, incomplete cross tolerance. So you can see 30 percentage of 30 milligram is 9 milligram. So we reduce 9 milligram from the calculated 30 milligram of methadone. So total it is 21 milligram. And then I told you there is something called the 3 day switch. 3 day switch means on the first day, you will give 1/3 of the total methadone, and then on the same day you will reduce the morphine by 1/3. On the second day, you will give 2/3 of the calculated methadone, and morphine will be reduced to 1/3. And on the day 3, you will give full dose of methadone, and morphine will be stopped. So this is known as 3-day switch. But we were very fearful, and instead of 3-day switch, what we did is seen in this table. So you can see on day 1, what we did was we convert the total dose of methadone was 20 milligram, 21 milligram. So you can see we have started 1/3 of that methadone, that is 7.5 milligram, and 40 milligram of morphine we reduced 1/3, so it became 25 milligram Q4H. With this, for 3 days, the patient were able to sleep. And on the day 2, we didn't do anything. We waited till 7 days. And on the day 7, we converted or we added another 1/3 of methadone. So it became 5 milligram TID, and we reduced morphine by 1/3. So it became 15 milligram. So the patient's pain relief was improved. And on day 14, we converted methadone to full dose, that is 7.5 milligram TID, and stopped morphine. So with this, patient had excellent pain relief, and the patient actually, I told you, who was restricted to the bed on the first floor of the house, she actually came to us by walking to express her gratitude to us. So that was the as I told you, that was the first, one of the first patients for whom we did start on methadone and got good pain relief. So why this patient got good pain relief, even though she underwent many or took many analgesics like morphine, tricyclic antidepressants, anticonvulsants, steroids, then epidural analgesia. It did not give her satisfactory pain relief. So what was the properties, or what are the actions by which methadone gives this good pain relief? So we have to understand that methadone is an isomer of S-methadone and R-methadone. Okay, so the methadone available to us, it may be tablets, syrup, or anything else. It is an isomer of R-methadone and S-methadone. And this acts as an agonist on all the opioid receptors, mu, kappa, and delta. Can anybody tell me where does the morphine act? On which receptor or the receptors morphine act? Anybody? Yeah, Dr. Ramadevi says me. Dr. Madhu also says mu, potash. Yeah, thank you. So morphine is a mu agonist, but you can see here methadone is an agonist at all the receptors, mu, delta, and kappa. Okay. In addition, it is also an NMDA antagonist. NMDA means N-methyl D-aspartate antagonist. So, which is the other useful NMDA antagonist you know? It's NMDA antagonist you know? Ketamine, yeah. It's ketamine, not ketorolac. Ketorolac is NSAID, whereas ketamine is an NMDA antagonist. Okay. So methadone also acts like an NMDA antagonist. Okay. Then it also inhibits the reuptake of noradrenaline and serotonin. So which group of medication has this mechanism? Which other group of medication has reuptake inhibition of serotonin and noradrenaline. Anybody? Antidepressants. Okay, yeah, tramadol does have this action, and Dr. Swati, you are correct, but specifically, there are many groups of antidepressants. SSRIs doesn't have this property. There are tricyclic antidepressants, and SNRIs have the reuptake inhibition of serotonin and noradrenaline. So amitriptyline, norepinephrine, independent. Those are the medications, or even duloxetine. Those are the medication that has serotonin and noradrenaline reuptake inhibition. Okay, so methadone acts by three mechanisms. It acts on all the opioid receptors. It acts as an NMDA antagonist. It acts like tricyclic antidepressants. And there is one more action, that is it inhibits human either agogo related channel. Okay, so when this channel is inhibited, it causes or it increases the QT interval, which lead on to tossed points and the sudden death of the patient. So this is one of the side effects, and the physicians are very reluctant to prescribe methadone because of this tossed points. Okay. So let's see what are the clinical impacts due to opioid receptor agonistic property. So as all of you know, when an opioid acts on opioid receptor as an agonist, it will have an analgesic effect. But in addition, it can also have other side effects, like it may cause sedation, constipation, nausea, vomiting, urinary retention, edema, and maybe very, very rarely respiratory depression. And we also told that methadone is an NMDA antagonist. So look here, there are 4 patients, A, B, C, and D. And the patient A is taking almost 12,000 milligram of morphine per day. Whereas patient B, about 9,000 milligram of morphine. Patient C, 3,000 milligram, and patient D, 1,000 milligram. So can any of you tell me what you mean by tolerance? What is tolerance? You can unmute and speak. Anybody? Diminished effect on prolonged use by Dr. Swati. Dr. Govinda says reduced pharmacological effect. Yeah, both are correct. So diminished effect on prolonged use, or to get the same effect, you have to use a huge amount of the same medication. Okay. So probably all these patients might have developed tolerance. That's why they are on such high doses of morphine equivalent opioids. And it is said that the NMDA receptors play a role in the development of tolerance. Okay. So all these patients were started on 30 milligram of methadone, regardless of the dose of morphine these patients are on. So when these patients, all the patients were started on 30 milligram of methadone, and all of these patients got good pain relief, which indicates the role of methadone in preventing and reversing the tolerance. Okay. So the development of tolerance NMDA receptors play an important role. So that's why when these patients are started on methadone, all of them got pain. So methadone can actually prevent and reverse tolerance, as well as we know that it would have an additional advantage in neuropathic pain. And the next clinical property is because of the tricyclic antidepressant-like action. So all of you know that it can produce, it is a tricyclic antidepressants are one of the mainstays for treating neuropathic pain. But you have to also understand that this can also produce something called as serotonin syndrome if you start methadone along with these medications. So you can see most of the antidepressants like fluoxetine, sertraline, paroxetine, clomipramine, MAO inhibitors. And when you start methadone along with these medications, there is a high risk of producing serotonin syndrome. Whereas this group of medications has medium risk and this group of medication has low risk. This is not only the problem with the methadone, but this can also occur with tramadol. And if you start tramadol along with the medications which are described here, it can also produce serotonin syndrome. Okay. So how can you detect serotonin syndrome? It has multiple manifestations. It can produce cognitive changes, autonomic instability, neuromuscular changes. And if uh, if the patient is on a methadone and you have started him on some tricyclic antidepressants or SSRIs, and the patient has agitation, hypothermia, tremor, cogwheel rigidity, then um, just think whether it is due to serotonin syndrome. So you can see a lot of symptoms are there. Uh, so this is just for you to understand there is something called serotonin syndrome, and it can occur not only with methadone, but if you combine any two medications which uh, causes or which inhibits the effect of serotonin, it can cause serotonin syndrome. And the next, so the first three clinical impacts which we have described, the action on opioid receptors, NMDA antagonistic action, and tricyclic antidepressant-like action. All those were beneficial effects. But now we are coming to an action which is not beneficial. So this is because of the action on human either a go-go related gene channel. So as I told you, it can increase the QT interval and which can lead on to prostate points and sudden death of the patient. So we described the patient, the young lady who had severe pain, and she didn't get any pain relief with morphine, tricyclics, pregabalin, uh, epidural analgesia. So probably because of the three actions which we have described, the action on opioid receptors, tricyclic antidepressant-like action, and NMDA and agonistic action. Those were the actions which they have been relief. Okay. So there are many cardiac risk factors for torsade points. So you can see electrolyte abnormalities like hypocalcemia, hypokalemia, hypomagnesemia. All these are risk factors for torsade points. Age more than 68 years, female gender, structural heart disease. There are many things, including malignancy. And another thing which you have to notice, when the dose of methadone goes above 45 milligram per day, that's also an additional risk for developing torsade points. So as I told you, it can it can produce torsade points, and most of these studies on torsade points are from patients who are on substitution therapy with methadone for opioid dependence. So you know that methadone is used for two purposes. One is for treating pain, and the other is for treating opioid dependence. So this is one study which was conducted by MD Anderson Cancer Center, and they did a prospective study in 100 cancer patients. And they started all these patients on methadone, and they took ECGs at baseline, then at 2 weeks, 4 weeks, and 8 weeks. What they found out was there were no patients who had torsades or ventricular fibrillation. There was some increase in QT interval, but no patients no patients had torsades points or ventricular fibrillation. All these patients, you can see the median methadone dose was 23 milligram. So this is one study which says us that when you use a reduced dose of methadone, maybe less than 45 milligram per day, then probably it is safe and it may not reduce torsades points or ventricular fibrillation. Okay. You have to understand that there are many medications when you use or these are the medications which can increase the QT interval as well as it can produce torsades points when you use along with methadone. So most of these medications are commonly used by the palliative care physician. You can see um, fluoroquinolones like the ciprofloxacin, levofloxacin, uh, norfloxacin, all this can produce, they have great risk. Then macrolide antibiotics like azithromycin, clarithromycin, erythromycin. Then fluconazole, citalopram, haloperidol. So these are the drugs or medications which we commonly use in palliative care. So when you start a patient on methadone, be careful whether are we prescribing or are these patients already on these medications? Because if they are on these medications, then the risk of increasing the QT interval and torsades points are more. I told you previously that methadone is used for two purposes. One is to treat opioid dependence, and the other one is pain management. We already talked about adverse effects previously. Now we'll move on to pharmacokinetics. So the methadone is also observed from the upper small intestine like morphine. But compared to morphine, methadone can be administered sublingually, and 30 to 36% can be absorbed sublingually, and it can give painfully. But morphine should not be given sublingually. It is not easily absorbed through the sublingual route. But methadone can be given sublingually, and it can also be given parenterally. And if there is injectable preparation, we can give it subcutaneous as well as intravenous. But in India, we do not have an injectable preparation. Okay. So after absorption, metabolism takes place in liver, and after absorption, it is distributed in the body, and it is mainly concentrated in brain, GIT, kidney, liver, muscles, and lung. So you can see when you administer methadone for the first time, you can see it in the blood for 2 to 4 hours, and after that, it will be going into the tissue binding sites, which we have already taught, like brain, GIT, kidney, liver, muscles, and lung. And when the tissue binding sites are saturated, then methadone will be gradually liberated continuously into the bloodstream. Only a very small fraction of methadone will be liberated into the blood continuously. The most important thing is that when the tissue binding sites are saturated, then only you will get sustained pain. So for this saturation to occur, it will take about 5 to 7 days. Okay. So that means the patients will have good pain relief only by 5 to 7 days. But if you give morphine to a patient, uh, what is the duration or what is the time uh, which requires for a sustained blood level in case of morphine? Time required for morphine to have a sustained blood level. Anybody? Anybody? Just okay. Uh, so, in case of opioids, it requires 5 half-lives to have sustained blood level. Okay. So, in case of morphine, the half-life is roughly 4 hours. So, that's why um, so it will take about 20 hours, 5 into 4, 20 hours. Or you can say 3 to 5 hours. So 5 into 5, 25 hours. That means 1 day. Morphine will take 1 day to have sustained blood level. So that's why you increase the dose of morphine every 24 hours. But in case of methadone, the half-life is about 22 hours. That means 1 day. And if you take 5 half-life, that is 5 days minimum. Okay. So methadone will take about 5 days to have sustained blood level. And that's the time when methadone will give you good pain relief. But in case of elderly and who has liver problems, it will take even more, maybe up to 10 to 14 days um, to have the sustained blood level. So in case of elderly and patients who have liver problems, you have to wait for 10 to 14 days before you increase the dose of methadone. And in normal patients, you have to wait for 5 to 7 days before increasing the dose of methadone. So this is one of the most important things you have to understand about methadone. Okay. Now the metabolism. It takes place mainly in liver. Uh, so uh, it is the metabolism is mainly due to cytochrome P enzymes, and various cytochrome P enzymes are involved. Cytochrome P to D6 to D6 C19. What essentially you have to understand is there are many medications that we use commonly. They are also metabolized through the cytochrome P enzymes. So methadone can have drug interaction with those medications. So this is another important point that you have to understand. So I am giving you some examples of drug interactions. There are both cytochrome P inhibitors as well as cytochrome P inducers. So in case of cytochrome P inhibitors, this is the mnemonic GFAT9, that is grapefruit protease inhibitors. What are protease inhibitors? Anybody? What is it used? Protease inhibitors. Yes, Dr. Saudi. Yeah, you are correct. So protease inhibitors are antiretroviral medications. Then azole antifungal like fluconazole, which we use very commonly. Then cyclosporin, cimetidine, macrolide antibiotics, erythromycin, clarithromycin, azithromycin. Then amiodarone and non-hydropyridine calcium channel blockers like verapamil and lutetiazide. So these are cytochrome P inhibitors. This is just examples. There are many other medications which are cytochrome P inhibitors. So when you give cytochrome P inhibitors like this medication along with methadone, what happens is it will inhibit the cytochrome enzyme and causes increased levels of methadone in the blood, which can actually produce toxicities. So when you start a patient, when you start uh, a patient on azithromycin, clarithromycin, haloperidol, and the patient is on methadone, then you have to be careful because you are going to increase the blood level of methadone. So you have to either reduce the dose of methadone by 25%, or you have to find some alternatives. So instead of azithromycin or erythromycin, can you give amoxicillin, which doesn't have much interaction with methadone? So these are the things which you have to understand. And then cytochrome P inducers. So carbamazepine is one of the strong cytochrome P inducer. Okay. So in addition of carbamazepine, smoking, phenytoin, all these are inducers, and this will reduce the level of methadone in the blood. So if you give this medication along with methadone, you have to see whether the patient is getting more pain, because the methadone level will be reduced, which can produce more pain. Okay. So you can see these are the medications. I am not going to read this, but just read note some of the medications like citalopram, escitalopram, sertraline, uh, esomeprazole, lansoprazole, omeprazole, pantoprazole. So all the PPIs, then ciprofloxacin, fluoroquinolones, macrolide antibiotics. So those can actually increase the methadone levels. And there are a lot other medications which can reduce the methadone levels. So how is methadone excreted from the body? Can anybody tell me how morphine is excreted from the body? Anybody? Which route morphine is excreted from the body? Hepatorenal pathway. Okay. It's morphine is excreted, yeah. It's by renal route, by glomerular filtration. But methadone is mainly excreted through bowel. Okay. Uh, so it is supposed to be um, a good analgesic in patients with chronic kidney disease. Okay. And what is the duration of action of methadone? It is about 8 to 12 hours. So you need to administer only twice a day or thrice a day. But in case of morphine, what is the duration of action of methadone? It's 3 to 5 hours, or roughly we can say 4 hours. So we have to administer every 4 hours. But methadone need to be administered only twice a day or thrice a day. So now we will move on to patients for whom we can start methadone, or appropriate uh, patients for starting methadone. Methadone can be used as an adjunct. So um, you know that uh, what is the definition of adjunct? Can anybody tell me what is adjunct analysis? What are adjunct analysis? Okay, add-on medication. Anybody else? Yeah, examples are correct, but how do you define an adjunct? So these are medications whose primary action is not pain relief, but is helpful in some painful conditions. Okay, so if you take tricyclic antidepressants, the primary action is not analgesic action. The primary action is antidepressant action, but it's helpful in some painful conditions like neuropathic pain. So that's an adjunct analysis. But here you can see that methadone is primarily an analgesic, but when methadone is given in small doses along with other opioids, it is called as an adjunct in the literature. So suppose an example, a patient who is on maybe 20 milligram of morphine 4 hourly. Patient has good pain relief most of the time, but at night time patient wakes up due to pain. So if you start uh, small dose of methadone like 1 milligram or 2.5 milligram for that patient, then the patient can have good pain relief. And if you use methadone like this, it is called as an adjunct. Okay. Then pain refractory to other opioids. You use many opioids like tramadol, morphine, fentanyl, and some people use buprenorphine. And none of this gives pain relief. So you can call it as pain refractory to other opioids. So this is one condition that you can use methadone. In patients with significant renal impairment. So I told you methadone can be one of the choice in patients for treating pain with chronic kidney disease. And as we already discussed, methadone need to be administered only twice or thrice a day. It is a long-acting opioid, and we already saw the four patients who are on thousands of milligrams of morphine, and when we started them on methadone, they got good pain relief. So patients who are on high doses of opioids, or there is some rare condition called opioid-induced hyperalgesia. Sometimes opioids can produce hyperalgesia very rarely, and in such condition also, methadone is a drug of choice. And if the patient has poorly controlled adverse effects like delirium or myoclonus, then methadone can be used. If the patient is allergic to another medication like morphine, some patients may complain that I am allergic to morphine. And if it is a true allergy, that is the anaphylaxis, then you can start the patient on methadone because methadone is from another chemical group. And patients with complex neuropathic pain is another indication. So our young patient, the young lady who had severe, or you can say complex neuropathic pain, when you started her on methadone, she got good pain relief. So these are the patients for whom we can start methadone. And there are some candidates for which, for whom you should not start methadone. If there is a family history of sudden unexplained death, then congenital QT syndrome and corrected QT interval is more than 500 milliseconds without modifiable risk factors. So let me ask you, what is the normal corrected QT interval? Normal QTC. Anybody? So it is for 50 milliseconds in males and for 60 milliseconds in females. Okay. And if the patient has poor cognitive function, we will not be able to assess the pain relief and the patient will not be able to express. So in such patients, we should not start on methadone, and another condition is that patient should have a reliable caregiver to administer methadone properly. And if we are unable to follow up the patient, we should not start patient on methadone. If the patient has acute pain, um, methadone is not a choice because it will take about 5 to 7 days. So in patients with acute pain, either injectable fentanyl or injectable morphine, that will be the drug of choice. When you start methadone, what all should be monitored? You can see what investigations should we do. It depends on the goals of care. If the patient is taking only comfort care, then we need not do aggressive monitoring. But if the patient is uh, undergoing any curative treatment, then we need to do aggressive monitoring. So the baseline, you can do an ECG to uh, monitor QTC and electrolytes, calcium, potassium, and magnesium, because low levels of this can cause increased QT. Then next ECG can be done 2 to 4 weeks after the initiation of methadone. Then when the dose reaches to 30 to 40 milligram, another ECG, and another one when it reaches to 100 milligram. But you have to understand that you may not come across such a situation where you need to start a patient on 100 milligram. We usually start with a low dose according to the uh, conversion method, and may go up to 40-45 milligram. Within that, most of the patients or almost all patients will have the pain relief. And if there is no pain relief with the 30 to 40 milligram of methadone per day, then you have to think whether there is any other factors like psychosocial factors which is influencing the pain. Okay. So this is the morphine tablet and syrup available in India. This is RMET 5 milligram tablet, and syrup 1 ml contains 5 milligram of methadone. So now we will move on to methadone conversion. So most importantly, methadone doesn't have a linear conversion ratio. That means when I ask, if I ask you 300 milligram of tramadol, what is the equivalent morphine dose you should give? 300 milligram of oral tramadol, what is the equivalent morphine dose? Can anybody tell me? 5 milligram. Okay. Any other response? Okay. For this, we have to understand the potency of opioids, and the potency of opioids are always compared to morphine. Okay. So the potency of tramadol is 1 1/10 compared to morphine. That means 300 milligram of tramadol means when you convert to uh, morphine, it is 300 divided by 10. That is 30. And 300 milligram of tramadol is equivalent to 30 milligram of morphine. Likewise, codeine 300 milligram, it is almost 1/10. So you can take it as 30 milligram. 200 milligram of tramadol, again 200 by 10. It is 20 milligram. But um, when you convert patient to methadone, there is no, you cannot take this, there is no fixed ratio. The ratio changes depending on the dose of methadone. Okay. So when you convert a patient from another opioid to methadone, first you have to calculate what is the equivalent dose of morphine. Okay. So the first method which I showed you when I presented the patient history is something which we do not use now. That was used only for a few patients. And when this paper, the hospice and palliative care physicians consensus white paper on methadone was available in 2019. We are using this method, which is very simple method and very conservative method. So you can safely use this method for converting morphine to methadone. So you can see if the patient is not taking any opioids or if the patient is taking less than 60 milligram of oral morphine equivalent per day, the starting dose of methadone is 1 milligram 12 hourly to 2.5 milligram 8 hourly. That means 2 to 7.5 milligram per day. Okay. But if the patient is taking 60 to 199 milligram of oral morphine equivalent per day, and if the patient is taking and if patient is less than 65 years old, the conversion ratio is 10 is to 1. Okay. If the patient is taking 60 to 199 milligram of oral morphine equivalent and less than 65 years old, then conversion ratio is 10 is to 1. That means 100 milligram of oral morphine would be equal to 100 by 10. That is 10 milligram of methadone. But if the patient is taking more than 200 milligram of oral morphine equivalent, or if the patient is more than 65 years old, then conversion rate is 22. So this is what I told you. Methadone doesn't have a linear conversion ratio. It varies depending on the dose of morphine the patient is taking. And another important thing is that whatever be the dose of morphine, suppose the patient is taking 12,000 milligram. That means patient is taking more than 200 milligram. So the ratio is 20 to 1. That means 12,000 divided by 20. That would be 600 milligram of methadone. We would never start methadone like that. The maximum dose that you will start is 30 to 40 milligram. Okay, whatever be the dose. So that's another important point that you have to keep in your mind. And how do you increase the dose of methadone? There are many complicated methods, but just keep this in mind. If the patient is taking less than 30 milligram of methadone per day, you can increase 5 milligrams of methadone and then wait for another 7 days. But if the patient is taking more than 30 milligrams of methadone, increase 10 milligram and wait for another 7 days. So this is how you have to increase the dose of methadone. Now we will move on to some patient story, and we will see how to convert a patient to methadone. So this is a 37-year-old man who had carcinoma of the buccal mucosa in 2018, and he also had another second primary papillary carcinoma of the thyroid, for which he underwent surgery and radiation. In 2019, he had a level 2 nodule recurrence and he underwent surgery. And his main problem thereafter was severe pain. So you can see the pain and the distribution. He says it is starting inside the left ear, going to the lateral side of forehead, then to submental region, which is pricking in nature and pains for it 10 by 10. So you can see the pink shaded area on this face. That is the mandibular nerve area, is the place where he is describing pain. So it is a neuropathic pain. And because of that, the treating team tried extra oral mandibular nerve block thrice from outside. There is no relief. You can see the patient sitting near the table with his head down. And because that was not effective, then they tried injection morphine, which reduced toxicities. And then they reduced the dose and started on tab morphine like this 10, 15, 10, and 30 milligram with 10 milligram SOS. Even they gave it only 4 times daily because of toxicity. Um, and they also tried him on various adjuvants, and there were no satisfactory clinically. When the patient came to us, these were the medication he was taking: tab morphine, pantoprazole, ciprofloxacin, acetylopram, ceftriaxone, diclofenac patch, paracetamol 650 milligram one SOS. Suppose we are going to start this patient on methadone. What are the indications to start patient on methadone? So we already talked about the candidates or the patient for whom we can start methadone. So what are those indications here? Please give your answers in the chat. Yeah, morphine toxicity. Yeah, very good, Dr. Guminda. Anything else? Any other indication to start this patient on methadone? Breakthrough pain is not an indication. Morphine not enough. Morphine toxicity. That's the right answer. Yeah, you can say it is an opioid refractory pain. Yeah, that's true. And you can also say that's a complex neuropathic pain, isn't it? So complex neuropathic pain, morphine toxicities, and not responding to other opioids. So these are the indications to start this patient on methadone. So before starting patient on methadone, what all would you ask? What all we need to ask before starting the patient on methadone? You have to ask about history of sudden unexplained death in family because there are congenital QT syndrome which can produce sudden death, and there is no cause which we can judge. So history of sudden unexplained death. Anything else you need to ask? Is there a reliable caregiver? Okay, so these are the two important things you have to ask. History of sudden unexplained death in the family, then reliable caregiver. What are the investigations you need to do? ECG and yeah, electrolytes. Electrolytes. Yeah. So sodium, potassium, and calcium. So these are the investigations that you do. And if you suspect any liver problem, you can also do liver function test. Do you have any concerns with the present medication? So these were the medications the patient was on. So we are going to start a patient on methadone. So do you have any concerns with the present medications? Ciprofloxacin, yes. Anything else? Yes, acetylopram. Yes, that's right. Anything else? Any other medications have interactions with methadone? I told you proton pump inhibitors. So pantoprazole is also another concern. So these are the medications which has interactions. Okay. So now we need to calculate the dose of methadone. So this is the these are the medications. And can you calculate the dose of methadone this patient needs? I have already shown you the white paper consensus method to convert morphine to methadone. So please calculate the dose of methadone. You can see one answer by Dr. Manoj. Says 2.5 milligram, 2.5 milligram, 8 hours. Okay. Anybody else calculated? Dr. Manoj, can you say how did you get 2.5 milligram 8 hourly? Okay, let's see. So this patient is taking, you can see total of 65 milligram of morphine, isn't it? 10, 15, 10, 13. So that would be 65 milligram. And what is the conversion ratio? When the patient is taking morphine equivalent between 60 to 199 milligram, and if the patient is less than 65 years, the conversion ratio is 10:1. Okay. So here the patient age is 37 years, and he is taking 65 milligram of oral morphine equivalent. So the conversion factor is 1/10. So the total dose of morphine required would be, methadone would be 6.5 milligram. So if you have only tablet methadone, then you can start with 2.5 milligram, that is total 5 milligram. But if you have syrup, start him on 3 milligram daily, that would be equivalent to 6 milligram. What could you do with morphine? Because this will take about 5 to 7 days to have sustained pain relief. You have to continue morphine on a 4-hourly SOS basis. Okay. So it is tab morphine 10 milligram Q4H on an SOS basis. But if you prescribe morphine for a normal patient, that's tab morphine 10 milligram Q4H and SOS. Okay, that is in addition to 4-hourly morphine, you will give SOS. But here it is 4-hourly SOS. So if the patient needs, suppose you administered methadone at 6 a.m., 2.5 milligram you have given. At 6 a.m., you will ask the patient, do you have pain? Patient says, no, I don't have pain. So you will not give morphine. You will skip that. At 10 a.m., you can again ask, do you have pain? Patient says, yes, I have pain. Give 10 milligram of morphine. At 2 p.m., you will again ask. Patient says, no, I do not have pain. Don't give. So that's what 10 milligram Q4X SOS means. Okay. So now the prescription would be like this: tab methadone, tab morphine, and we added paracetamol 750 milligrams 6 hourly. And instead of azithromycin, we gave amoxicillin. Ciprofloxacin, we gave amoxicillin because ciprofloxacin has interactions with methadone. Then we stopped escitalopram. The treating team started him on escitalopram, thinking that patient is in severe depression. But the problem was that he didn't have good pain relief. That was the problem causing him depressed mood. So when the patient was on methadone, within 3 days, the patient got good pain relief, and even we didn't think that he will have good pain relief. That was the situation. And this patient actually lived for uh, till his death pain free, and he was very active. So this is another patient, a 39-year-old woman with carcinoma of the pancreas with stage carcinoma of the pancreas stage 4 with liver, lung, and splenic metastasis. And she was on chemotherapy, but after 5 cycles, the oncologist told her to stop it because the disease was not responding. And she was receiving the palliative care from the oncologist, and her main problem was the pain. You can see the pain pattern, which starts on the left lateral chest and going on to the back. And the pain score is always 10 by 10, which comes down to 8 by 10 after taking morphine, tramadol, and paracetamol. Uh, so these were the medications she was taking. Tab morphine 20 milligram, Q6 hourly, injection tramadol 100 milligram IV TID, paracetamol 1 gram 6 hourly IV, gabapentin 100 milligram TID, amitriptyline 25 milligram HS, bisoprolol 5 milligram 2 HS. With this medication, she had myoclonus. So, is this patient a candidate for methadone? If so, what are the indications? What are the indications? Indications, please. Patient has opiotoxicities. She has myoclonus. Okay. It seems like a neuropathic pain. And she is on tramadol and morphine. Still, she does not have pain relief. So it is refractory to other opioids. Okay. So investigations. What are the investigations you need to do? ECG and electrolytes. Actually, this patient, we need not do all these investigations because now the goals of care has changed from the curative to comfort care. So it is okay if you do not do ECG or calcium potassium magnesium. So what would be the dose of methadone? So these are the medications. These are the medications. Can you calculate the dose of methadone? Please calculate. I'll give you 1 minute to calculate. I can see some answers here. 2.5 milligram TID. Okay. So let's see. So methadone dose, when you calculate methadone dose, you have to convert all the opioids to morphine. here the patient is taking morphine. In addition, she is also taking tramadol. So you have to also convert tramadol to morphine. So oral morphine, she is taking 80 milligrams, but she is also taking tramadol. So she is taking total 300 milligram of tramadol, injection tramadol, 100 milligram IV TID. So total tramadol, it is 300 milligram. And when you convert it to morphine, you have to divide it by 10. So this is the oral morphine equivalent dose of tramadol, that is 30 milligram. So the total dose of morphine equivalent she is taking is 110 milligram. And conversion ratio, age is 39, and she is taking morphine between 60 to 199 milligram. So the conversion ratio is 10:1. So the methadone would be 11 milligram. So start with methadone 5 milligram BD, and you also okay. So that's the dose of methadone 5 milligram BD. Do you have any concerns with the present medication? So we have converted morphine and tramadol to methadone, and the rest of the medication, paracetamol, gabapentin, amitriptyline, disacodine. Do you have any observations against these medications? Amitriptyline, yes, Dr. Gunnar. Amitriptyline has interaction with methadone, but here it is a very small dose. So either you can continue to give amitriptyline or you can stop. But amitriptyline has some interaction with methadone. So this is how we started here. Tab methadone 5 milligram BD, and you have to continue morphine on a 4-hourly SOS basis. Gabapentin and amitriptyline was continued. So this is another lady who actually was very sad because she was unable to do anything for her young children as well as for her husband. She was fully dependent on others, and she was bedridden due to pain. And after starting her methadone, there was 2 months for which she lived. She had a very good life, excellent quality of life, excellent pain, and she was very active. She could do all those things what she wanted to. So this is another patient. So this is just the first 2 were real stories, and those were the patients for whom we started the methadone. And this is another patient just to calculate the dose of. So this is a patient who is taking tab morphine 40 milligram 4-hourly, and it is a 40-year-old. There is no pain relief. Suppose you want to start this patient on methadone, what would be the dose? Please calculate.
कितने मैच खेल लिए?
Anybody got answers? Okay, 16 mg methadone. Okay, Dr. Patel says 5 milligram TID. Okay, let's see. So it is 40 milligram for hour, isn't it? So what is the total dose of morphine he is taking? It is 240 milligram. So what would be the conversion factor? It is 20, because if the dose of oral morphine equivalent is more than 200 milligram, or if the patient is more than 65 years old, conversion ratio is 20:1. So it is 240 divided by 20. It is 12 milligram of methadone. Okay. If any of you are interested to know more about the cytochrome interactions, which are the medications we need to avoid, etc., then there is a website and another website for understanding for this, to know the medications which can increase the QT interval, and there is another website. So please go and visit this. And in summary, what I want to tell you is methadone is actually a very good opioid in appropriate patients. So you have to select the patients for starting methadone. So we talked about who are the appropriate candidates. Some of the indications are patients who has chronic kidney disease and need pain management. Patients with complex neuropathic pain, patients with opioid toxicities, patients with allergy to other opioids, and then it can be also used as an adjuvant. Patients who are on high doses of opioids because of tolerance or opioid-induced hyperactivity. So these are some indications. And whenever you see patients, please look at them and see whether are there any of the indications for starting the methadone. And even many patients might have undergone interventional pain procedures, but even they may not have pain relief. For those patients also, methadone might give good pain relief. So I have already described two of my experience. Whenever you start patients on methadone, the investigations that you or the monitoring parameters are ECG and electrolytes, and if possible, you should call and ask the patients every day regarding the pain relief and the side effects. Maybe at least 5 to 7 days. And then methadone is not like morphine because you have to wait till 5 to 7 days to get good pain relief or to have sustained blood levels. But in case of morphine, you can increase the dose every 24 hours. So methadone is not a good medication for managing acute pain. But acute pain can be managed with the morphine or injection therapy. Then the torsade points. That is the main concern while you prescribe methadone. But there are 1 or 2 studies which says with lower doses of methadone, it is safe and you can safely start patients on methadone. So thank you. And if you have any doubts, please.
Thank you, sir. Thank you so much. I believe we lost Radha.
No. I'm there. I'm there. Thank you very much, Dr. Sunil. Like as we are aware, this like methadone is something many people may not be aware. And next thing is that coming to know that it's available in India. And many do have patients who may not be able to get good pain relief with morphine. So in those type of situations, we have something else, which is one more thing I wanted to add on is it's cheap. It's again not expensive, isn't it? They should know how to use it. Because many people will come to a situation where they may not be able to get adequate pain relief with the morphine. So some patients can get them to a situation like that. So they have another alternative, something to be aware of. Cost-wise, do you want to add on anything, Dr. Sunil? You
Was
were
there
muted. And now we can hear you.
okay? Was there a question? I couldn't actually hear.
No. Cost wise, I just wanted to say that this is also something which is cheap and available. Anything you wanted to add on for that?
Yeah. So when you take morphine, methadone, tramadol, tapentadol, buprenorphine, fentanyl, the cheaper drugs or cheaper opioids are morphine and methadone. All the other medications are costlier. And actually, morphine, the cost of methadone is comparable to morphine. And if a patient is on high doses of morphine, and if you convert it to methadone, then the cost would be even less than morphine.
Exactly. That's what I just wanted to say, that so that people can be aware, and then like getting these narcotic drugs available, no essential narcotics like that, they can get this one. They have to be aware of. Only important thing with methadone is they should know how to use it. And for that, they have had an extensive session today, which will help them. And there were no more questions in the chat. As always, we have said, no, any one of you have any doubt, please unmute and ask or type in the chat. What is the chemical?
Oh,
Chemical composition.
I cannot comment on that, but I will. I will try to get it. Please continue.
That's all. We will pass on the information, Dr. Narayan. I think it was Dr. Narayan and yes, Narayan and Venkatesh, which will be passed on through the group and the communication.
Okay.
Somebody wants to ask anything, please go ahead.
Yeah, I just wanted to know whether the methadone or the morphine conversion, is it equivalent with the one that we are doing with the opioid substitution therapy?
It would be entirely different. It is not equivalent to opioid substitution therapy, and the patients who are opioid dependents, they will need high doses of methadone, maybe hundreds of milligrams of methadone. But pain relief, we have. I hope you were there in the class when we talked about the conversions. So I will tell you once again, if the patient is taking less than 60 milligrams of morphine per day, then the conversion ratio would be 2 to 7.5 milligram per day. If the patient is taking 60 to 199 milligram of morphine equivalent, and if the patient is less than 65 years old, the conversion ratio is 10:1. That means 100 milligram of, if the patient is taking 100 milligram of methadone, 90 milligram of methadone, that is 15 milligram Q4 hourly. That would be equivalent to 90 milligram of morphine. And if you convert, that would be 90 divided by 10. That is 9 milligram of methadone per day. And if the patient is taking more than 200 milligram of morphine, or if the patient is more than 65 years old, the conversion ratio is 10:1. That is, suppose the patient is taking 400 milligram of morphine equivalent, then conversion ratio is 10:1. That is 400 divided by 20. That would be equal to 20 milligram of methadone per day.
So basically what the whole session we have tried is, it's not a linear conversion as you have like this generally what you do with fentanyl and all, you have a table. That type of conversion, fixed or easy conversion doesn't exist. You have to follow what, and that is the latest what Dr. Sunil has explained once again. That is what has to be followed. So you have to see the age of the patient and then the total dosage per day. And if it is less than 200 or more than 200, you will follow different conversion factors. And then the age of the patient also. Less than 65, you will follow one conversion ratio. patient is more than 65, you will follow. So these are things which you have to follow. And then the longer duration, how you have the morphine as 4th-hourly SOS. You ask and give. So all which was explained is important, because you should never end up getting an overdose. So that is why patient has to be followed up. You have to review. You should have an attender or a carer. All these things which have been reiterated have to be kept in mind. Is that clear? Was that Dr. Brogan who was asking?
Yeah, I was asking, yeah, I understand the conversion one. I was just asking with the methadone substitution therapy, is any, it's quite different, as Sunil has already answered that one. Yeah.
Exactly. Yes,
Thank
that's
you.
all. Most welcome. So I wanted to make sure your query has been answered. That was the main thing, Dr. Brogan. There are no more queries in the chat, Sri Priya. I think I will hand it over to you.
Thank you, ma'am. Thank you, Sunil sir, for being part of us in the last session. So I know that.
1 minute. The methadone comes under the chemical class called diphenylheptanes. Okay, diphenylheptanes. Whereas morphine, codeine, hydromorphone, all those come under phenandrines. And fentanyl, alphenanyl, all those come under phenylpiperidines. So that those are the chemical classes. Dr. Narayan, for your information. Yeah,
Thank you, Dr. Sunil. He has also replied to that. Go ahead, Sri Priya.
Thank you. Thank you, sir. We know that your day has not even ended yet, and still you found out time for this wonderful batch. You enlightened us on one of the most important topics of methadone. So that brings us to the end of our official sessions. Now it is the time for feedback. So we would like to hear a few words from some of you regarding the areas of improvement for us as the facilitator and coordinator of this program, as regarding the entire program, what all was good, what all could be done better. We would like to hear from you all.
Ma'am, everything was good, but except for the fact that this session could have been done in that allotted time, because some of the assignments we found it a little difficult to answer regarding the questions on methadone. So skipping this what to say, like not conducting this session at the in this last session. Probably it's a little difficult for us also to answer all those
Completely
questions.
understood, ma'am. Yes, that was a really unavoidable situation that we had to postpone this session. Otherwise, if you could remember correctly, this was the 5th session we had planned because of the importance of the topic. Yes, point well taken. We will definitely see to it that even if some sessions are getting postponed, we will try to include those in the nearest date possible. Thank you for that feedback. Anyone else would like to add in?
Madam, the assignments were really very useful for us. So they enriched our knowledge very much.
Thank you, sir. Thank you. Any other quick comments on? Actually, we are looking for some points of improvement. Me and Radha ma'am specifically, because we always try to do things better, right, ma'am?
Exactly. See, you all can suggest like anything with the study material or the content covered or anything like that. If any of you want to add on, because see, this case discussions, someone has mentioned, Sri Priya, audios can be improved. Some days, yes, like I think 1 or 2 sessions we had issues with. See, that is, I think, more to do with the internet facility with the person who is the faculty in their area or something like that. We did have, Sri Priya, if I'm not wrong, we had ones with one of the presentation, I think, what was it, Dr. Arjun, from when he was doing it
Yes.
from his hospital.
Mm.
So if I'm not wrong, I think, so those are
Correct.
things, no, like it is more to do with the local area internet facility. Unfortunately, we will try what much improvement can be done. Thank you for that. That is what has been mentioned.
And
And then
Dr.
something they
Swati
has asked for something else, Sri Priya. Mail not received, so some technical team can improve, and maybe communication.
Yes, I will just go through them one by one. I think we had first the comment from Dr. Swati saying some of the sessions case presentations got skipped. Yes, Dr. Swati, of course, we always try to bring in case presentations as much as possible for all the sessions. Yes, but when the participants are not available, suppose there were even days on which we had 4 case presentations, there were 4 participants, but unfortunately none of them were available to present the case. Yes, we had said that we will be presenting the case on their behalf if there is prior information, but then again, some cases would be so critical that the exact professional who had handled the case should be present in the session for answering the queries. In such cases, we definitely have had to skip some sessions without cases. Yes, we also do feel really bad about that because we understand that case discussions are the most vital part of our foundation courses. Point well taken, ma'am. Yes, of course, in future coming batches, we will definitely take better care of that. Radha, ma'am, you would like to add anything?
Exactly. See, one of these days, which when we did, I was about to say, was a psychological topic. Psychological issues were the topic, and in that, the main issue is the thing what the patient and the carer are going through. Like me and Sri Priya can read out the case. We went into that stage that we will do that, but if what are the issues that the patient and family are facing, if that we both may not be able to say, because that person who was to present was unfortunately not able to attend that session. So that was one of the things. Otherwise, most of the times I will tell Sri Priya that I am willing to present because we had cases. So that was the reason why. Sorry, but again, case presentation, we will look into that. And that's why, no, so from that point of view, if more people submit cases, and we do encourage that as part of the assessment also. So we will reiterate that once again and take it forward.
We have 2 questions regarding the assignments, the discussion of assignments. Yes, we would humbly like to inform that as per the current SOPs and guidelines, we are not in a position to discuss the assignments openly in the platform. But yes, of course, you are really very free to connect with Dr. Radha or any of our faculty panel members to discuss specific questions in which you have queries. We will definitely make sure that those queries are getting addressed as soon as possible. Because it is really unfortunate that we also know that it is bad that we are not sharing the answer keys directly, but our SOPs won't allow that. Yes, we are working on that. Maybe in coming days that would happen. But as of now, you are free to discuss each and every question individually where you have queries with either the esteemed facilitator or the other members of the faculty panel. Hope that answers.
Exactly. Anything like that, they could communicate to you, or you can get in touch with me, Sri Priya, and then we will go ahead with that. You get in touch with concerned people, and then whatever still needs solving or settling, please get in touch with me. As we always say, we are here to help you, and not only now, down the line, whenever you all want to move forward and start your setup also, we have our regional coordinators to help you, and Sri Priya is always there to help us. And then so get in touch, anything, any local, even your hands-on. I would recommend all of you, please go ahead and attend at least a 5 days or 10 days hands-on in the nearest center, which has been shared with you.
Dr. Kannan, yes, yours was a particular case, specific case. Tech team could not unfortunately do anything with you, but I believe that you're receiving the links in time and we're joining the classes in time as well. Okay, Dr. Jyoti, thank you for those kind words. Dr. Harini, thank you so much. Thank you, Dr. Mamta. Thank you, Dr. Swati. I believe that we are running much ahead of time now. Sunil sir, would you like to address anything as the director of our entire program to the audience?
First of all, I would like to thank all of you, and we consider it as our privilege to have you with us for the last few months. And we are sure that you will help a lot of patients. And, we see in India or country without much suffering, and all of you will be a part, will be doing your part in relieving the sufferings of lots of patients. And for that single reason, we are very thankful to all of you. Thank you very much.
Madam, I got one request.
Go
Hello?
ahead. Go
Madam,
ahead.
so in the
Can you
beginning,
tell your name?
Dr. Narayan V,
Dr.
madam.
Narayanan.
Yes, madam.
Narayanan, go ahead.
So in the beginning, they had told us that after giving training to us, we have to improve the curriculum in our colleges. So we will be involved in disseminating the knowledge regarding palliative care to our students. So when will that be done, madam?
No, where
Sir,
from you are? Which institution you are?
I am from Father Muller Medical College, Mangalore, madam.
Okay.
yes, sir. I would like to take up that question. Most of the participants in this batch are will be definitely moving on to the faculty development program as proposed. That would take at least 2 weeks to 4 weeks time as of now, sir, because first we have to summarize all the scorings in the foundation part. We will have to ensure that all the eminent faculties get certified in the foundation part, and then we will be moving ahead with the faculty development program, which would be a 5-day program, 5-day session, 1 week session online, and other details will be communicated to you in coming days. Yes, of course, it will be there within 2 to 4 weeks time.
Okay. Thank you, ma'am. Thank you, ma'am.
Before closing the session, I would also like to announce another program which we have started. That is an online module of palliative care, which is known as Essentials of Palliative Care India, which you can do as per your convenience. And the details can be seen in our website. So if any of your friends who is unable to join the foundation course in palliative medicine because of the time restraints, then please convey them. There is another program which they can do according to their convenience.
Thank you, sir. Even though that would mean missing interaction with the live coordinators like me, yes, of course, you are free to join such courses. Radha ma'am, over to you.
See, various, because the Palim is trying to cater to people who say that, no, this is not possible for me. So that's why varied type of options are there. And then on top of that, as you mentioned, no, this once you are all trained, then you slowly become trainers for the next people in your own facility. Like you can become trainers for your nurses, social workers. So in many ways, this can be taken forward. So that is how the main aim of the whole program is. Okay. And once again, thank you one and all. Very interactive it has been, and it's been a large group. So hope everyone is able to render whatever is their aim and ultimate thing that they are looking at. Thank you, Sri Priya. I would just.
Thank you, everyone. So regarding the particular course which Sunil sir said, we would, jokes apart, we would strongly recommend that course to your staff nurses, especially because this particular course is having option for nurses as well. It is for doctors and nurses, and Many times as coordinators, we have seen that it is the nurses who find it really hard to cope up with the schedules and all when it comes to the foundation courses. So in case you want to build up your team, you want to make sure that all your staff members, your staff nurses are also getting trained like yourself, please do recommend that course. It's we will definitely be sharing the further details of the course along with brochure in 1 or 2 days time in the, so please look out for that. So if anyone, no one else has anything more to share, I think we can call it a day off. Thank you everyone for being part of this wonderful journey, and we do hope that you are able to spread this news of palliative medicine in your areas of work. This is Sri Priya along with Dr. Radha Venkateshan and Dr. Sunil Kumar signing off for the last time from Tips Eco Hub. Stay connected through WhatsApp and mail. We are always there to support you. Thank you everyone. Take care. Bye-bye.
Thank you and good wishes to one and all. Thank you.